Good morning all. Thanks for having me here. Thanks to the organizers for giving me this opportunity. This talk is a huge switch from what you heard earlier. So I'm from Center for Brain Research, and I'll be talking on causal graph representation of a cohort using clinical dementia ratings or CDR scores. Now here's the universal truth. As we age, our cognitive abilities keep decreasing. But when we age healthily, the decline is not so rapid. But when there is neurodegeneration, the decline is huge. So the challenge is to identify neurodegeneration to facilitate intervention before it's too late. And this degeneration happens in stages. At first, only the subject is aware. And then there is a time when the subject wants to look for assistance. And then the rapid is just to decline. Now, what's dementia? It's decline in thinking, decline in memory, decline in reasoning abilities. There are cognitive impairments. It hampers life. So we've all heard this term somewhere or the other, right? There are various types of dementias. It could be Alzheimer's, it could be vascular, it could be Lewy body. So several conditions come under this umbrella term. There are several groups around the world that are working on this. Prominent ones are ADNI, the Alzheimer's Disease Neuroimaging Initiative. There's Alzheimer's Association. There is LASI that focuses on Indian data. There's Mayo Clinic Study of Aging, which looks at Hispanic. ADNI looks at Caucasian. So there are several groups around the world working on this. It's because it's prevalent worldwide. It's uncurable. So these groups, what do? They share insights on causes, progression, how to manage, how to look at intervention strategies. But most important of all, they make data available for research, which is a huge thing. Genetic data, neuroimaging data, blood profiles, and so on. Now, dementia causes lots of changes. Structural changes are very apparent. What you see on the left is a normal brain. What you see on the right is a demented one. You see all of these. There's thinning of cerebral cortex. There's fragmentation of gray matter, enlargement of ventricles. These are like textbook symptoms. Loss of white matter volume. All of these are clearly visible on MR images. You see this enlargement of ventricles. There's widening of sulcus. So the difference is apparent. There are differences in functioning, definitely. What you see on the left is how a normal brain would react. The activation maps you see here, they are all for a normal brain. An Alzheimer's brain would look like this. So the functioning is far reduced. So dementia diagnosis can happen in different ways. You can have cognitive assessments. One prominent way of doing it is to use clinical dementia ratings. You can have blood tests. You can have CSF tests, imaging, genetics, different combinations. So there are various ways of diagnosing. But we are all looking for what is the best way, what is the way that can catch it earliest. So in today's talk, we are looking at cognitive assessments, definitely not the earliest way. Why is it? Because manifestation of dementia happens in stages. The red curve you see here, that tells you about the amyloid plaques. So way before the subject realizes that something is off, amyloid plaques are already happening. So unless there is reason to investigate that, that stage is crossed, right? And then there is tau misfolding. That happens much later. Much later comes the structural changes, the functional changes, which can be captured by neuroimaging modalities. But if the subject is unsuspecting, there is no reason for him to think. There's no family history. There's no reason for any other tests. By the time the person realizes he's already in this green zone, where so much has already happened. So for an unsuspecting subject, cognitive assessments become the first diagnostic tool. So here's a small outline of what we are going to cover. We will look at what these clinical dementia ratings means, what's a causal graph, some data sets that we've used, and what we conclude. First, the CDR scores. When the subject walks in suspecting something is amiss, the physician gives him a set of questionnaires or a set of activities to assess 6 main subdomains. They are as follows: memory, orientation, judgment and problem solving, community affairs, home and hobbies, personal care. These are fairly standardized. Anywhere in the world, any physician who's testing the person for dementia will look at these. So each subdomain is rated by the practitioner in discrete steps: 0, half, 1, 2, and so on. Now all of these 6 domains that are assessed, they are all combined to generate one output, the clinical dementia rating score. And how do we interpret this score? 0 stands for healthy, half is MCI. MCI is mild cognitive impairment, where things are just beginning to decline. 1 stands for mild dementia, 2 for moderate, 3 for Alzheimer's, gets severe and severe. Now, please don't be bogged down by this. I just wanted to show you that there's a standard way in which practitioners assess. For example, how is memory assessed? For it to be healthy, there has to be no memory loss or very slight inconsistent forgetfulness. So there is a standard set of guidelines laid down for the doctors to give those certain scores. When it is this, you give 0. When it satisfies this, you give half, and so on. For each of the 6 subdomains, you see guidelines are very well laid out. So no matter who's assessing you, the scores are standardized. In '93, Morris came up with a way of combining these scores from the CDR subdomain scores. So this is from his original paper. I want to show you that the way of assigning the final score is so twisted. So there is no analytical way of writing it. There are lots of if, else if. So as you can see here, see, memory is considered the primary category, all others are secondary. So the final score is equal to memory score if something. It is something else. So it's a very, very twisted way of arriving at the original score. I'm sure lots of thinking went into it, and that is the best way of doing it. So there are lots of calculators. You input what the subdomain scores are, and it will give you what the output scores should be. So there is nothing for you to hand calculate. So this one, for instance, I entered zeros everywhere, and fair enough, the person is healthy. So the final score is 0. But if I had some other combination of zeros, half, 1, or whatever, I'd get some other score. So there are several such calculators that give you the score. Now the questions that we tried to ask with these scores are twofold. The first question we tried to ask: can we utilize these clinical dementia scores to understand what are the interactions across the subdomains? For example, personal care is one subdomain, judgment is another. So personal care is affecting judgment, or is it the other way? Or judgment is affecting personal care? So can we capture these interactions? That was the first question. The second is, if I have diverse populations, diverse cohorts, are these interactions identical or are they different? For example, if I look at the Caucasian population from ADNI, and let's say we come across with this kind of interaction, that orientation is affecting judgment with this weightage. So does it mean that this relation is true even for Indian subjects? Is it the same across different populations? So we addressed this in one of our accepted works in Journal of Alzheimer's Disease. So the two data sets we used here are ADNI, which looks at majorly Caucasian population, and LASI, which looks at the Indian population. I want to thank my co-authors for this. So what is it that we are trying to arrive at? What do these subdomain interactions look like? Is it something like this? Is it something like this? So the space of possibilities is like exponentially huge. Which of them is right? So these are just illustrative. So let's come to what is a causal graph. causal graph, or directed acyclic graph, DAGs. Now, what is causal graph? It's a graphical representation of a data generating process. So this is where it's very different from the traditional machine learning. Traditional machine learning just looks at curve fitting. They don't bother about the process that gave rise to the data. So as a simple example, let's look at X indicating the amount of rainfall, Y indicating the amount of water in a lake. So let's say we have this table. So we can clearly see as X is increasing, Y is increasing, X decreases, Y decreases. So what is the goal? I want to arrive at the data generating process. So the causal graph should give me X and Y are the two nodes, and the arrow goes from X to Y, meaning that rainfall comes first and that flows into the lake. But is this obvious from the table? It is not. From the table can also give you the other way around, right? Think of Newton's second law, force equals mass into acceleration. So if you just tabulate force and the acceleration, there's no way you can say whether acceleration came first or force came first, right? So it's hard to establish causality just by looking at observational data if the physical process is unknown. So this is where causal learning becomes more than just curve fitting. So when we have more than two variables, there are questions that we can answer about causality. So one of the very few instances where having more makes it simpler, makes it possible to solve. So these are the subunits of a causal graph. When I have two variables, I can have a direct cause. Either A is influencing B or B is influencing A. Now, when I look at triplets, there can be multiple configurations. There can be a chain kind of thing. A is influencing B, B is influencing C. There can be a common cause where A influences both B and C, or there can be a common effect where A and B are both influencing C. So all of these, to figure out which of these is right, we have to compute these conditional probabilities, right? Which we can do using observations. So all of these probabilities can be established from observational data. Hence, all of these independent testing can be carried out. And reliability of the independence tests will depend on how good our data sets is and how many realizations we have. So larger the data sets, greater the reliability. We'll go into this. Now there are some assumptions we have to make before we start building the causal graph. The very first one is causal Markov condition. It says statistical dependencies emerge from causal relations. That is, I have two variables X and Y. If they are correlated, then one of these three should happen. X is the cause of Y, or Y is the cause of X, or there is a common cause Z that causes both. So this is the first assumption. Second says faithfulness. What does it mean? If we are seeing independence in probability distribution, it should imply that there is independence in the graph also. There is separation in the graph. So this is faithfulness. Why is this arrow this way? It is actually both ways if both 1 and 2 are satisfied. So if I have causal Markov and faithfulness together, then it ensures that it's if and only if. It's both ways. So if I know separation in graph, it means there is independence in probability distribution. If I know there is independence in probability distribution, there is separation in graph. So we used Peter Clark algorithm. It's a very famous one of 1993. So we are aiming to build causal graph using observational data. That is the objective. So let's say we have a tabular data like this. There are 4 variables, A, B, C, D. There are values we see for each of them. And this is, let's say, the kind of causal graph we want to arrive at. We can incorporate domain knowledge. The more we can incorporate, the better. So domain knowledge can be incorporated to make it more meaningful. For example, here, if we know that D is the output node, the simplest thing we can do is there is no outgoing arrow from D. Everything should be entering D. That's the only constraint. So let's see how this algorithm works. For each of the variables, we create a node. For example, if this is the true graph, there are 5 nodes for 5 variables. We start off with the assumption that all are connected to each other. So at first we have a very dense graph. Everything is connected to everything else. Then we go about pruning. You will eliminate connections if the variables are uncorrelated. That is complete independence, right? If A and B are independent, I don't need that edge. I'll cut that. And so you come up with what is called the skeleton of the graph. So now what is missing are the arrows, the directionality, which is so critical. So that's where we will look at the triplets. So we know triplets can be in any of these 3 configurations. It can be indirect, it can be common cause, it can be common effect. So what do? Pick up 2 variables and start conditioning it on a subset of variables. So if it is following indirect cause or common cause, you will see that A and C become independent conditioned on the observation of B, if it is like this, right? If you know my mother, you don't need to know my grandmother. That is what it says. Now common cause, so B and C, they become independent conditioned on this observation. We'll see one example to illustrate that. And common effect says A and B become dependent conditioned on C. We'll quickly see what it means. So this is a common cause. When there is viral infection, we generally associate it with fever, we associate it with body ache. But when I know that a person has viral infection, the person might have fever, the person might also have body ache, so we can't say for sure. So these 2 become independent when I observe this, right? So B and C become independent when A is observed. And then the common effect case, it's a collider. Why collider? Because two nodes are affecting in a way that they collide. For example, I'm looking at the common weight of 2 vegetables, carrots and potatoes. When I don't know what the weight is, carrots can have any weight, potato can have any weight. But once I begin observing what the common weight is, knowing about the carrot will fix what the weight of the potato should be, right? So if I fix the observed weight, knowing about carrots will tell me what is the potato weight, right? So A and B become dependent conditioned on C. Now a simple example of a 3-node causal graph. Anyone who's done causal graphs has seen this example before. There are 3 random variables: rain, sprinkler, wet grass. It's the simplest case because they can take only 2 values. It's either raining or not, sprinkler is either on or off, and grass is either wet or not. So I want to create a causal graph from the observations. So from the observations, I can come up with these probability tables. The probability of rain, probability of no rain, probability of sprinkler on if rain, probability of sprinkler on if no rain, and so on, right? So these are the truth tables we have, the probability tables we have. From them, we construct this causal graph. So we got these directions. Rain is impacting sprinkler, and the 2 together are impacting wet grass. So this is a collider, right? So we got the arrows and arrow directions, but how did we get the weights? That requires a separate modeling called structural equation modeling. What happens here? Here, for example, W is affected by X. So I will say W is assigned by some F1 of X. Now Z is affected by X. So Z is some F2 of X, and so on. So for simplicity, we assume linear functions, and we determine the parameters. So that will give us these numbers, the weights. So at the end of this exercise, what did we get? We got this causal graph along with weights. So causal graph facilitates evaluation of intervention. Now what is an intervention? Without physically performing the experiment, using a very recent framework, thanks to Julia Pearl, called do calculus. We'll quickly see what it means. Now we have the causal graph. Yeah. I want to evaluate an intervention. That is, what's an intervention? Intervention is not a part of the observation. It is something we are enforcing. Let's say I want to have the intervention, sprinkler is always off. And then I want to evaluate the condition of grass. So you enforce a value at a node, which is an intervention that needs to be computed without actually performing the experiment. See the kind of freedom it gives you. You don't need to manipulate. You can just compute it. So here you will compute the probability of the status of grass given this intervention. This, mind you, is very different from the conditional probability, which can be read off the observation table. Now what does this have to do with the clinical dementia scores? So we had this set of scores for so many subjects. For each of the 6 domains, we had these evaluations by physicians and their final score. Here, what is the domain knowledge we will use? That the CDR global is the output, everything else are the inputs. So here we used data sets of 2 types, ADNI, which is Caucasian, and LASI, which is Indian. We tried to use a large data set, respectable number, 13,000 from ADNI and 3K from the Indian data set. And this is the causal graph we got over 13,000 subjects of ADNI. As you can see, it's a dense graph. You see the weightage from memory to the output is the highest, which is exactly how the maker of this rule had first suggested. And you compare it with what we got for Indian subjects, it's a very, very sparse graph. So there are lots of commonalities and differences between the two. One glance will tell you how different they are, but then there are some similarities that we saw. We saw that the edge from memory to the output is the highest in both the cases, which is very, it gives a lot of credibility to this method. We also saw that the edge from PC, that is personal care, to CA has the same directionality and has the least edge strength. So that's another similarity. Yet another, from orientation to CDR, is the second highest in both the cases. Lots of similarities here, but then lots of differences also. One major difference we saw is that the orientation and home hobbies nodes, many subdomains feed them, but not in LASI. A quick look at it. You see this? Home and hobbies are fed by many subdomains in ADNI, but not in LASI. Yeah, I'm done. So what is the advantage of this representation? What did we achieve by doing this? We can now think of intervening at one node and then evaluate what the output difference is going to be like without actually doing the experiment, which is a big thing, right? You just can't intervene on a cohort and say all should follow this. So the advantage of this kind of a representation, you're now representing a cohort, right? You're representing 13,000 people with one graph. So you can start looking at how similar two cohorts are, how different they are. So it captures the impact of environment on the cohort subdomain interactions. It gives you a framework to compute the impact of intervention using do calculus, and it can be extended to devise what is an optimal strategy, what is the best node to intervene on. And it also shows you that what you devise for one cohort cannot be blindly used for another, because there is no one solution fits all. Each cohort is different. So in conclusion, for neurodegeneration studies, we can leverage explainable AI to understand and design optimal interventions. Representation bias has to be addressed, since not all categories of any disorder can have fair representation. As we saw, 0 and half had the maximum number of subjects. As the as CDR value kept increasing, number of subjects kept decreasing. And the more diverse data we have, we can build more robust models. Thank you. Yeah.
Thank you so much for the wonderful talk.
Thanks.
Questions?
So we saw that sample size has quite a bit of effect on your outcomes. Is
yes,
it true?
sample size will determine the reliability of the independence test. So what we did, out of 13K, we split it into two, 6.5, 6.5, and computed the DAG. And we arrived at the same DAG.
So did you also try to kind of partition or randomly shuffle and then do many trials to see, how, just like you do bootstrapping or things like that?
Right.
So are there any...
That we could do with ADNI, not with LASI, because the numbers were so small.
I see.
Yeah.
Thank you.
Yes.
Hello, ma'am. On what factors the directionality depends on the graph?
Yeah. So directionality is the all-important thing, right?
Yeah.
So we saw the colliders.
Yes.
We saw common cause, common effect. So we do these independence tests to determine the directionality.
All right.
So the reliability of the independence test will give credibility to the causality.
So the independency is depend upon the data set on what?
If your data set is clean
Yeah.
and you have large numbers, tests become more reliable.
Okay.
We do a chi-squared test because it's discrete.
Okay.
Yeah.
Fine. Thank you, ma'am.
Thanks.
Hi,
Right? Yeah, sorry. Yeah.
my name is Devashish Tripathi. So
Yes.
I have a basic question that usually when we do causal inference, we first construct the DAG.
You
That's
first
a-
construct the DAG.
Right. That's our generative mechanism. And then we try to test the DAG with the object data. But you have gone the other way around.
No. From the observations, you construct DAG.
No.
So
So,
when you start, you have only the table.
right.
And you have to discover what is the process that generated this table.
Yeah, so you have gone the other way around. I mean, you have used the object data to generate the DAG.
Yes.
Right.
Yes.
So, I mean, if you look into the epidemiology or you look into the clinical trials, what usually happens that you first construct the DAG and
Acha.
then you use the object data essentially to isolate the effect of whatever the factors you are looking
Okay.
into. I mean, the only question I have is that because you are generating it from the object data, how we basically distinct between the statistical association. So if X is associated with Y is also associated with X. So then the direction is essentially you are deriving from the object data.
Yeah,
So
that
that's
is where those collided common cause, common effect triplets, those play a big role. They give you the direction of the arrow.
So we can talk.
Definitely.
Hello, ma'am.
Hi.
Very nice talk.
Thanks.
So, in your slides, you mentioned
Sorry. Yeah.
in your slides you mentioned something about judgment. So, like, can you explain what judgment is? Are there any series of tests that you're performing? Is there any score that by which you can?
Now, those are standard questionnaires or activities that practitioners all around the world are given.
Okay.
So those 6 domains, those are standardized. So
Okay.
how do you test memory? How do you test orientation? Those are all medical knowledge.
Okay.
We do not know those.
Okay.
Yeah.
It's like recently I had the privilege to work on some questionnaire data.
Yes.
So have you, like this is a publicly available data.
Right.
So have you ever wondered like there could be some latent variables which could be existing within the subdomains? I mean, I know this is a
I'm
standard.
sure there are, but the very assumption in building the causal graph is there are no confounders.
Okay, because
Yeah.
population difference we have to consider.
I'm sure there is so much more.
Okay.
And there's no ground truth we can evaluate against, right?
Okay.
We can only see those sanity checks.
Because recently I went through one of the questionnaires and then I found like most subdomains were there in the questionnaire when I got for a different population.
Right.
But again it is like, and there are some original subdomains also, it's not like it completely it has diverged. So now that is the thing. So latent variable could
You
actually
see,
help.
there are no confounders.
Hmm,
That's a very big assumption.
Okay.
Yes.
The second part of the question is that since we are going with the causal like association, we could also try to connect the clinical available test results. Like for example, the tests are there, blood tests are there, and the graphs are also there.
I'm sure,
So
yeah.
we have this like Mendelian randomization. I think like
Yes.
it's a very popular trend,
Yes.
right? These.
This was just a pilot work. We just had this tabular data and we saw what can we do with it.
Okay.
Yeah.
Thank you so much.
Thanks.
Hello.
Hi.
In your results, you saw a different relation between O and H. If you consider that in LASI compared to the previous data set,
Right.
what is the how the interpretation changes of the final score?
So it tells you that the environment, the lifestyle is playing a role in which subdomain is pushing what, right? You see, especially home and hobbies is so different across the two. So we know our societies are so different. So maybe that's playing a role. So we are just trying to capture what these differences are. You see, the home and hobbies was very busy for ADNI. There are lots of interactions there, but not like that for Indians. There's no ground truth, right?
Any other questions? Okay, thank you so much.
Thanks so much.